Very good morning. Today we'll be seeing a rare case, myxoid glioneuronal tumor of the central nervous system. Now this tumor has been included under the glioneuronal and the neuronal tumors of the CNS in the 5th edition of WHO. Outline of today's talk includes introduction, clinical features, imaging findings of myxoid glioneuronal tumor and its differential diagnosis, macroscopic and microscopic findings, immunoprofile, genetic profile, and prognosis. Coming to introduction, the glioneuronal and neuronal tumors constitute a group of morphologically heterogeneous tumors showing neuronal with or without glial differentiation. These frequently occur in the pediatric age group and young adult group. These patients present with intractable epilepsy or obstructive features, whereas pressure symptoms and neurological deficits are rare. These are low-grade circumscribed, slow-growing tumors with relatively indolent biological behavior. And these tumors lack molecular alterations associated with diffuse gliomas. So these are the group of these are the tumors coming under glioneuronal and neuronal tumors, out of which these two, that is diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters, and myxoid glioneuronal tumors have been incorporated in the new WHO. So coming to definition of myxoid glioneuronal tumor, it is a low-grade glioneuronal tumor typically arising in the septum pellucidum, corpus callosum, or periventricular white matter. The tumor is characterized by proliferation of oligodendroglial-like cells embedded in prominent myxoid stroma, often admixed floating neurons, neurocytic rosettes, or perivascular neuropil. These correspond to CNS WHO grade 1 tumors. Epidemiology. These are rare primary brain tumors and less than 100 cases have been reported to date. Age group is children and young adults, and the male is to female ratio is equal. Now these patients present with headache, emesis, seizures and behavioral disturbance. These are located in the septum pellucidum, septal nuclei, genu of corpus callosum, and periventricular white matter of the lateral ventricles. Imaging findings. On MRI, these are well circumscribed lesions which are hypointense on T1 weighted images, and on T2 these appear as hyperintense without contrast enhancement or restriction diffusion. The tumors which are epicentered in the septal nuclei lead to obstructive hydrocephalus. Disseminated disease may be present throughout the ventricular system at the time of initial presentation. Coming to differential diagnosis on imaging, colloid cyst, central neurocytoma, and subependymoma. Now, colloid cysts, these occur in third to fourth decade, and these are classically well delineated hyperattenuated mass on unenhanced CT attached to anterosuperior portion of the third ventricle. On MRI, they are usually hyperintense on T1 and isointense to brain on T2. Coming to the second DD, central neurocytoma, the age group of presentation is second to fourth decade. These are T1 isointense to gray matter and heterogeneous, and on T2 or flare, typically iso to hyperintense as compared to brain. And this tumor shows numerous cystic areas leading to bubbly, Swiss cheese or soap bubble appearance. The next is the subependymoma. Now the age group is much higher, that is fifth to sixth decade, and these are well delineated, round to oval shaped lobulated masses with intratumoral cysts. Now these tumors may be heterogeneous also, and calcification contributes to the heterogeneity. Now we start with our case. This is a 4-year-old girl who complained of headache, blurring of vision, and increase in the head size. So the MRI revealed a well-defined lobulated intraventricular solid cystic lesion which measured 8 into 5.8 into 4.6 centimeters, epicentered in the septum pellucidum. This girl was operated uh, by Dr. Uh, by Dr. Ishtiaq Ansari, the neurosurgeon at the Pacific Hospital, Aurangabad, and entire tumor was resected. So you can see there's complete resection of the tumor. So these are the post-op scans, and the course was uneventful, and patient was discharged without any deficit. So you can see this girl nicely smiling. So we received this in the lab, and you can see it is a lobulated lesion, and cut section shows typical soft myxoid areas. So coming to histopathology, this is a tumor showing proliferation of oligodendrocyte-like cells embedded in the myxoid stroma. There is a very delicate capillary network. We can see occasional floating neurons. Neurocytic rosettes or perivascular neuropil may be present in some cases. So the rosette forming glioneuronal tumor needs to be ruled out. Then myxoid glioneuronal tumor lack multinodularity with a rich nodular pattern, Rosenthal fibers, eosinophilic granular bodies, and microcalcifications, which are present in this embryoplastic neuroepithelial tumor of the cerebral cortex, and the mitotic activity is absent or low. So we went ahead with immunohistochemistry. The oligodendrocyte-like cells were strongly olic positive, GFAP positive, SOX10 was positive, CD34 was absent in the tumor cells. We did TTF1 to rule out choroid glioma. We also did IDH1 on IHC, which was negative. We went ahead with Sanger sequencing. IDH1 and 2 was negative. We also went ahead with the molecular studies to see the PDGRFA mutational analysis, and we got wild type on exon 12, exon 14, and exon 18. So there was absence of PDGRFA gene mutation in the given tumor. So we rendered a diagnosis of myxoid glioneuronal tumor, CNS WHO grade 1. Diagnostic molecular pathology. The myxoid glioneuronal tumors are known to show dinucleotide mutation in PDGRFA gene, which was absent in our case. Then these tumors typically lack the genetic alterations that are characterized by glioneuronal tumors and pilocytic astrocytomas. And there is a very distinct epigenetic signature found on DNA methylation profile, which is closely related to this embryoplastic neuroepithelial tumor of the cerebral cortex. So coming to prognosis, the biological behavior is very indolent. All the cases reported in the literature are arrived. Local recurrence, progression, and dissemination is reported in minor. Take home message: myxoid glioneuronal tumor is a rare tumor, a new entity included under glioneuronal and the neuronal tumors. These are typically located in the septal nuclei and the septum pellucidum. Age group is children and young adults. Macroscopically, these are well-defined or well-delineated masses. On cut section, they are typically soft with myxoid areas. On microscopy, the tumor is composed of oligodendrocyte-like cells embedded in the myxoid stroma. The mitotic activity is rare or absent. Occasionally, floating neurons, neurocytic rosettes, or perivascular rosettes may be found. Necrosis, microvascular proliferation is absent. Coming to immunoprofile, the oligodendrocyte-like cells are GFAP and OLIG2 positive tumors. We need to rule out other entities such as chordoid glioma and oligodendrogliomas. The molecular study, that is PDGRFA mutational analysis, is should be done, and it is supportive of the diagnosis. Coming to prognosis, these are indolent, slow-growing tumors, and the outcome is favorable in absence of chemotherapy and radiotherapy. However, these can recur locally or may show ventricular dissemination. Less than 100 cases have been reported in the literature. Uh, Thank you very much. If you have any queries regarding myxoid glioneuronal tumor or any other tumors, kindly write to me in the comment box. If you want to know about any other tumors, you can write on my email ID, which is mentioned here. Thank you very much.